For joining.
Yeah.
I know it's late in the evening. I know people have better things to do, so I'll try to keep this quick and brief and informative. And if you have any questions, please ask at the end. So I was asked to talk about robotic surgery, and I was going to start out by talking really about why people get joint replacement surgery. It really starts mostly because of pain and a worn out joint. I've been practicing here in the Montgomery County area since 1995 and have been with the Shady Grove Orthopedic Practice since 1999. So today's topics will include understanding why your joints hurt, treatment options, non-operative and operative, and then joint replacement surgery and expectations for recovery. So when we're talking about surgery or joint replacement surgery, we're talking about having a replaced joint for end-stage arthritis. There are typically three types of arthritis that affect people's joints. One is rheumatoid arthritis, and this is a systemic type of arthritis where our immune system attacks the synovium to our joints, causes erosion changes of the entire joint and loss of cartilage. The most common, though, probably is what I see mostly is osteoarthritis. That's probably partially genetic, but also age-related, where the cushions between the bones wear down and we have bone on bone or arthritis. And I tell people that arthritis is very similar to a tire. We have cartilage in our knee, you have rubber on a tire, and when that wears out, that is really what arthritis is. Post-traumatic arthritis is also a common cause of arthritis, and that's usually due to a previous injury or surgery that was done years before. Why is it important? Because arthritis and pain limits our ability to move. Their joints are involved with walking and daily activities. What are the options for non-operative treatment? Well, there's walking aids, canes or crutches, which most people do not want to use, but this will unload a joint and make the joint feel better. Hot and cold therapy can provide short-term relief. I often tell patients after sporting activity or activity, use cold, and when things are achy and sore, apply heat. Heat usually increases blood flow and increases the relief of a stiff, painful joint. Physical therapy has some benefits in that you can strengthen the muscles around the joint, and hopefully the therapist can work with patients to individually help with their pain. Most of the time, patients will come to me and say, well, I can't exercise because it hurts too much. And so therapy is not always effective. And then most patients have already been taken the over-the-counter anti-inflammatories. There are prescription anti-inflammatories, probably not any more effective, but you can take those once or twice a day as opposed to the over-the-counter anti-inflammatories. When those fail, often patients will get a cortisone injection, and there are other types of lubricant injections. There's a lot of talk nowadays about stem cells and PRP, and there's no proven benefit from those treatment modalities. Probably does help the physician's income, though, because they're out of network and they're not covered by insurance plans. So when people start having joint pain, what do you have to ask yourself? And I tell you that, you try all the conservative things to do first prior to seeking, medical treatment. And if it's bothering you enough to see a physician, it's usually keeping you awake at night, usually stopping you from doing the things you want to do, and it just hurts because of the pain. When we talk about, end-stage arthritis and after patients have failed the conservative treatment, there is basically total knee replacement or partial knee replacements. And a total knee replacement is basically a resurfacing of the worn out joint. So we don't take a knee out and put a new knee in. We cut the ends of the bone and put a metal and plastic as a new joint surface instead of the cartilage. This picture here shows a normal healthy knee on the left, which shows that there's cartilage on the end of the bone, just like a chicken bone. There's that white glistening cartilage, which is the lubricant or the joint lining. And when we talk about the joint, we talk about three compartments in the knee. We talk about the inside of the knee or the medial compartment, the lateral compartment, which is out here, or the patellofemoral joint, which is underneath the kneecap. You can have wear in any or all of these areas. And we talk about total knee replacements, we're replacing the entire knee joint. People that typically have kneecap pain will hear that crunchy sound under the kneecap. It hurts in the front of the knee, usually hurts to go up and down steps. But people with arthritic kneecaps can live a lot longer and tolerate it more than they do than if they have the wear in the inside or the outside, because that's where it hurts to stand. And this is a picture over here of the diseased cartilage. And basically, you don't see it red, but you see loss of cartilage or flaking or thinning of the cartilage. Initially, you don't see anything on an X-ray. Over time, the joint space will narrow down. This is an X-ray of a normal knee, or what appears to be normal on the left side where there's a gap between the two bones. This is filled up with cartilage. And on the right side of this picture over here is where the inside or the medial compartment of this knee is completely worn out or is bone on bone. So I have a quick video here to show you basically what a knee replacement looks like. Started. Let me see if I can get this to work. There we go. There we go. Okay, so this is a normal knee moving through a range of motion. There's basically flexion and extension. This knee does not look great. There is some wear in there and there's no cartilage. And this is the operation that we replace the end of the bone with metal on the femur, metal and plastic on the tibia, and it just replaces the articular surface or the joint itself. And that's basically how it works. Other types of replacement are partial knee replacements, which I'm a big proponent of. This is called a uni-compartment knee replacement, and there are several joints in the knee that we replace. Primarily, most people have medial compartment arthritis, which is this picture here. You can have lateral compartment arthritis. You can have patellofemoral arthritis, which is shown here on the third picture. Or some people have bicompartmental arthritis, which is the kneecap and one of the inside or the outside. And the implants for these are either a partial medial compartment replacement, a lateral replacement, a kneecap replacement, which would be this one, or a bicompartment replacement will replace both the inside and the patellofemoral joint. This is a picture of the two type of different implants. So a partial knee would just replace the worn out side on the inside. A total knee replaces both compartments, or all three compartments actually. Most people will replace the kneecap. Some physicians do not do that. And here are the x-rays of the two different types of procedures. And you can see on this x-ray here that this is the right knee, this is the left knee. This left knee has narrowing in this joint, and they may be a candidate, may be having problems with this knee, requiring this type of operation. So these are what the implants look like. The Mako robotic knee surgery, which I'll get into, is basically proprietary, and they use two types of implants. One is called a triathlon for a total knee, and the other is a Restoris, which is for the partial knee. And they have this is a partial knee replacement for just an inside of the knee, and this is the patellofemoral replacement part that goes on the femur that replaces the kneecap worn out joint. The triathlon knee is specifically designed for Mako robotic surgery. It's a single radius of arc of motion, meaning that when you extend your knee or flex the knee, the gaps stay the same throughout a range of motion. And the benefit of a robotic surgery is that we can measure the gaps in flexion and extension and maintain the same width throughout. And so it's kind of an ideal setup, I think, for accuracy. This implant has been around for years. It's very common total knee replacement. It was placed in the knee prior to robotic surgery, so they have a long track record and history with it. Recently, there's been a push to do these knees cementless. Most of the time in the past, they were done with, we would cement them in. And there's sort of a gradual evolution and changing of that. So what does robotic surgery do? Well, robotic surgery, I think, is very accurate and very patient specific. So it starts out by getting a CAT scan of the individual patient, and then we can put the implant in somebody's knee prior to doing any surgery. So that workup is done prior to the day of surgery. And then in surgery, we do some manipulations with the knee, stress the ligaments, and balance the knee so we can rotate the implant to specifically fit each patient individually. So here it is. It starts out with a CAT scan, which gives the anatomy from your hip, your knee, down to your ankle so we can get good alignment. There's a 3D model that's done that can put the implant on the end of your knee, and then the total knee replacement, again, as I talked about, right now, the studies are showing that people have a little less pain than the old standard manual knee replacement. They have a little quicker recovery, and they have a little faster back to normal life. Partial knees, which I, again, am a big proponent of, have the same results, except I think patients recover approximately 2 weeks sooner than they do with the total knee. They feel a little bit more like a normal knee than a total knee does, and they're usually very happy. And I think it's, one of the best operations out there, honestly. So again, the Mako statistics has been around for 19 to 20 years. At this hospital where I've been doing it for over about 12 years, it came out of the partial knee, and then the total knee came out about 6 or 7 years ago. So I've been using it for over 12 years. And here is a little picture of the machine. When people talk about robotic surgery, it's really, I tell people, it's really computer aligned surgery. It's not a robot that goes in and does it. It's kind of like the self-driving cars. It's a haptic controlled saw blade that is predetermined. You make all your cuts, or you make all the alignment or the decisions to make your cuts prior to the robotic arm coming in, and then this guides you and protects you from cutting an abnormal cut or an abnormal angle to your saw cuts. So here's a quick video of a total knee replacement. So again, if you look at this CT scan, these are all images that are done prior to going into the operating room. So we know about the exact size of the implant and kind of location where we're going to put it. Intraoperatively, we will adjust the rotation of it and maybe what's called a varus or valgus angle to the implant, because we can make fine adjustments to fit each individual patient. So people want to know how long it takes to recover from joint replacement surgery. Honestly, that's variable. Often I'll have patients come in at 2 weeks, 4 weeks, 2 weeks, 6 weeks, and then 3 months. Most patients have recovered enough to resume the normal activity by 6 weeks with a total joint or even a partial, but there will be some stiffness and swelling which can go on for 9 to 12 months. And sometimes you have a few outliers that may not feel fully recovered for a year or two. typical joint replacement surgery now has evolved into an outpatient operation. People are usually doing home therapy for 2 weeks. And then they'll come to the office to get their sutures out, usually at 2 weeks, and then outpatient therapy. And then I usually see them back at that 2 weeks, 6 weeks, and 3 month period. And then again, yearly after that, just to make sure everything is going okay. And again, these are all averages. There's no specific time period for everybody, but in general, people are coming to the office in anywhere from 2 to 6 weeks walking with maybe a cane at most. But again, these are big operations, and patients do hurt and swell and do take a little time to recover from. What activities are advisable with joint replacement surgeries? Well, I tell all my patients that it's very difficult to make somebody 18 again. We're putting metal and plastic inside the joint, so it's a good operation when you fail conservative treatment and things are limiting your lifestyle. It's meant for getting back to normal non-impact exercises, meaning walking, driving, biking, swimming, golfing, dancing. Some people push it and run and do more aggressive activities. There's risk to that, but the big problem is the wear of the plastic inside the knee. These are sort of, in general, sports that are advised against. Now, I will say that some patients still compete in those, but those are not recommended activities once you've had a joint replacement. So if there's any questions, I'd be happy to take them. Oh, I did have one more video I wanted to show. How do I get out of it? I have a video that was that I made, actually my surgical assistant made for me several years ago when I started with the partial knee replacements. How do I get on my screen? Can I share that?
Yeah, just find the video.
So I have will this share?
Yeah.
So this was a video that was made in our office probably 7 or 8 years ago on the partial knee replacement. It kind of gives a demo, sort of what you've seen before, but this is going to the hospital and how the procedure is performed. So again, this is all done prior to making any individual cuts on the patient, so we know exactly where we want to put that implant prior to starting the procedure. And that's what the CT scan will help identify as the anatomy of everybody's individual knee. With the partial knee replacements, it's more of a burr than a saw. So we use a burr for partial knee replacements opposed to cutting with a saw blade. Questions?
Mm-hmm.
So I will read off some questions and hopefully give you the right answer. So the first question is, what's the lifespan of these replacements? Are cementless replacements easier to replace in the event of failure? So the reason people are switching over to cementless is because there's always this fear that the cement will wear out in 15 to 20 years. And so the expectation is that the cementless will not wear out and will last a little longer. I don't think that's been proven yet or out there. If you have a loose, I mean, people are using a lot less cement now, so revising any of these is a big deal. So taking it out and having to chip out the bone from a cementless, again, I'm not doing a lot of revisions, so having a big plug of cement in there is worse than a cementless knee replacement. The next question is, how do you decide if you use cement or cementless? Well, honestly, I will tell you that I've been doing cement my whole career and I've been very happy with it. There's new data out there that cementless is the new wave. I always hate to jump on the new wave. I did one several years. It's actually an easier operation, a little quicker. And I'm tempted to put my foot back in, but if you have one result where they didn't do so well, you kind of jump back to what you've been doing. So about 5 or 7 years ago, I did a cementless one and that patient did not do so well. So I've been cementing ever since. But I'm very tempted to go back in. I just don't want to, I'm scared about who the first patient was that I do the cementless on. Is this surgery covered by Medicare? Yes, everybody has to get authorized, but Medicare does approve partial and total knee replacements. What about pickleball after surgery? Well, to be honest with you, I'm considering having a partial knee done to myself so I can continue to play paddle tennis and pickleball, though it's against recommendation. So, I mean, I think pickleball is low impact and I would allow it. Are there any age limitations? We try to do these in older patients. I am a big proponent of doing partials in younger patients. This is not an operation for a 20 or 30-year-old, but so it's mostly recommended for older patients, and older is anywhere from 40 on up. The difference between the Mako and a Rosa that other doctors use, the Rosa was developed a little later after the Mako. It does not have the application for a partial knee replacement. I looked at it several years ago and I thought it was more of a hybrid cross between alignment rods and the exact numbers that I can get with the Mako. So I did not switch over to that. That's a different company. But I am a big believer in the Mako system. The videos were supposed to have sound. I'm sorry if you could not hear those. Are there any contraindications for this type of implant for a total knee replacement? Probably the only real contraindication is an active infection. Somebody that has neuropathy or no sensation in a joint is a contraindication. There are questionable metal allergies out there. And nickel is in most implants. There's a very, very rare chance of a nickel allergy. So there is a different implant that I've used that does not go with a Mako. That's not supposed to have any nickel, but that is supposedly a very rare complication. How long till driving with a total knee replacement? Well, that is a very debatable question, depending on right or left knee. I usually go by once you are putting full weight on it, you have good control of your leg and you're off narcotics, then if it's your right knee, on average, I would say it's about 6 weeks. With your left knee, that could be up to 2 weeks. My opinion on gel injections, I think it's no harm. That insurance covers it. It's not really proven procedure. Medicare does cover it and insurance companies will pay for it. And I have enough patients that get it and will come back every 6 months for a repeat injection. So they must be getting results. So I think that the data on it's not great, but it does seem to help enough people that they will do it. Could you weight train? I have one male who has a knee replacement and he bragged about lifting or squatting 500 pounds. Not my recommendation, but I mean, everybody has to be deciding on how old they are and what they want to do with the knee for longevity. As again, I said, I'm 62, thinking about having a partial knee so I can have it 10 more good years. Probably not advisable. And so I feel for patients and understand what they want to do. But, you know, can you weight train? Could you do some light jogging? The hope is you could do it. Is it advisable? Probably not. Is it a bloodless surgery? Well, we use tourniquet, so there's not a lot of bleeding during the time of surgery. After surgery, we usually put people on a blood thinner. Now we've progressed to just aspirin as a blood thinner. My training began with Coumadin, we went through a bunch of different medications, and now we've circled back to just aspirin. But some people bleed on aspirin and get bruising, so most people will get a swollen leg, bruising around the joint or below the knee to the ankle for several weeks afterwards. Can you kneel on partial or total knee replacements? It's hard to kneel on any incision. I've had a little small open procedure on one of my knees, and I still don't kneel on it. I think it's the scar tissue from that. Total knees are definitely harder to, most people do not like to kneel on a total knee. Partials, there's nothing usually there, that you're pressing on, except I think it's the incision that people don't like to kneel on. Can you do both knees at once? You can, it can be done. I have found mostly is that usually one knee hurts worse than the other. If you do one, patients often will put off the other one because for some reason it doesn't seem to hurt as much. The other one doesn't hurt as much after you've done one. Maybe that's the shock of how much it hurt to have the surgery, but a lot of times you were able to unload the painful joint because of your new replaced joint, and you decide, hey, I don't need to do this right away. So I think it's always advisable to do one at a time, not simultaneously. The only benefit of doing both at the same time is probably a little cost savings to the insurance company. I think the overall recovery is probably shortened to have two done at once, but the pain and the risk is a little higher to do two at one time. There was another question.
Oh, there's one.
So some doctors are doing minimally invasive or quadriceps sparing procedures. You spare cutting muscles and tendons. So I've done a few of those. It's kind of a little more of a struggle. I have not seen a difference in recovery replacement. Again, I think the most important is to make sure it's put in right. And with this robotic surgery, we have to put two pins in your femur. I usually stick those in the incision of the femur, and two pins were placed in the tibia outside the incision. So that kind of dictates how big it is. We also, with a total knee, you have to move the kneecap out of the way to get in there. So you're kind of doing the same stretching with a muscle sparing operation or with cutting through the quad. How long will the replacements last? Well, partial and totals have a pretty good track record of 15 to 20 years. So, I mean, I think they're very similar. People, a lot of times I get the question is if I'm going to get a partial, why do I want to do that if it's just going to wear and I'm going to have to do a total right away anyway? Well, I have been doing partials. I did them manually prior to the Mako coming out, which was over 10, 12 years ago. They are still lasting and doing fine. And the Makos, I think, are a little more accurate and they're not having to be revised. So they're lasting over 10 years that I've been putting them in. The totals, again, out there, not a lot of revisions have started to come around. So I think that we would like to get a 15 to 20 year life expectancy out of them. So people often ask if I hear clicking in the knee. Clicking is not an indication for surgery. It's an indication that something's clicking. It can be tendons, but if it doesn't hurt, leave it alone. So again, how long do they last? I think that's why we try to do them in the 50 and 60-year-olds or older, because they should hopefully last your entire life. A revision is a big operation. That is one reason why I'm a big proponent of doing the partial replacements, because I tell patients if you're in your 40s or 50s and you get a partial replacement, then it's much easier to revise that or add another partial to it than to take out a total and redo a total. And I think they both are lasting about the same amount of time. Asking me if this applies to hip replacement. There is the Mako robotic hip replacement. Not many people have done that. The software was a little more complicated. I actually stopped doing hip replacements, but if I was doing hip replacements and an anterior approach, I would probably have it done with the Mako robotic, because I think you don't have to use X-ray, where anterior approaches, they often will use X-ray for it. So, and hips are a little easier to recover from. So anybody out there that's had a hip replacement, they usually don't have as much stiffness and pain, and the recovery is a little quicker than knee replacement. Yes, alignment pins. Well, you don't use you use pins to connect to the robotic. It talks with the the computer navigation. So you put two fixed pins in the femur, two fixed pins in the tibia. You attach it looks like a radar detector that talks to the computer, and that it guides your cuts. And those come out at the end of the procedure. What is the ideal weight before surgery? Well, lighter is better. I mean, I have patients that tell me they can't lose weight. We try to keep, the biggest thing that we're seeing now is if your A1C is over 7.5, that's a contraindication to have a knee replacement or any surgery. Weight is a relative contraindication, makes the operation a little tougher. But there's not a specific cutoff for weight. Have I seen allergic reaction to cement? And I have not seen it to cement. I have not luckily had a patient with a metal allergy. And I have not had anybody really react to staple patient or an inpatient procedure. Well, I did 3 today. 2 are staying at the hospital overnight for a 23-hour admission because more for family situations, but most of these are being pushed to an outpatient type of procedure. As for partial knee replacement, could a partial replacement leave room for the other parts of the knee to be replaced and then another surgery? Yes. So it's off-label, but you could have like a medial compartment done, and then if the kneecap went or the outside went, you could add another partial knee to that. So again, another question about weight. Obviously, we try to get patients to lose weight prior to surgery. We know that's hard. Nowadays with the medications, we try to get, if they're really heavy, we will advocate for them to get on some of the medications that seem to be advantageous. But again, there's not a specific cutoff for weight or even age. I've had 90-year-olds that come in and, I tell them if they're hurting and they can't walk around, if they broke their hip, we'd fix it. So if their knees limiting their ability to walk, then, and if they're healthy enough and to undergo the procedure, then, yes, I think that they're candidate for it. So are the sutures self-dissolving? There are self-dissolving sutures that I've used. There are strips that can just like, there's a tape that kind of goes over that can be peeled off. It's not staples. And those work very well. You have to make sure you do a nice tight sub-Q closure. And then sometimes they'll ooze and just a little more problems with them than staples. But no, I use those also. So tennis after knee replacement surgeries. I would tell you that I think doubles tennis is okay, especially on a clay court. You're never going to be as fast as you were when you were 18. Again, that's why I push partial knee so people can be a little more active and feel more normal than the total knee. Again, these operations are to make you feel better. I don't think they make you 18 again. So if you're limited and you can't do certain things, this is an operation to help, but no guarantee that you can go back to, I would say tennis or competitive sports. So the revision rate, manipulation rate, I think it's definitely better. I think that those studies are not definitive yet. But I think with this robotic surgery, I always feel like I can sleep better at night because I know I put it in and I know the numbers. That's nice because when you do this operation, you can measure the angle of the knee, you can measure the flexion extension. The old method without robotic surgery, people would, I mean, every time I was with other surgeons that did the operation, they say, oh, it feels good, but there was not a specific number. Now I can look and say, okay, we're in 7 degrees of hyperextension. We've got a little flexion contraction of the knee. You can change the plastic, or you could recut if you need to make the measurements specifically how you want to. So PT is definitely recommended. I think that you definitely need to do exercise afterwards. Most people will be in a therapy program or an exercise program for 6 to 12 weeks. As again, I said, the first 2 weeks are usually home and then outpatient for 6 weeks. At that point, it's exercising, but you ought to continue exercise forever. And again, if you do it on your own, you're making improvement, then you don't have to come to a therapy facility. The knee replacement does correct partials and totals, usually to correct a curved leg. So if you're bow-legged, we often will do a medial compartment replacement that straightens your leg up. If you have a total knee, the goal is to realign it. And that's a nice thing about the robotic. So today I did somebody with 13 degrees of varus, meaning it curved in. We corrected it to about 6 or 7 degrees, meaning they were pretty straight at the end. Can one play casual softball? Um, I guess that's the definition of casual. You don't want to trip and fall and running down to first base and break your femur above a knee or below the knee. How long would you be on painkillers? Well, that is another variable. Partial knees come in usually at 2 weeks and are pretty much off everything. There's always those patients that call in within 4 to 6 weeks, still wanting something to help sleep at night or having some discomfort. Most people are off everything by 6 weeks. What is my opinion on plasma-enriched injections? I think there's no downside except for cost. There's no proof that it works for arthritis. It does seem to have some benefit for tendonitis, but I think it's not a proven method at this time. The partial knee replacements have the same, well, they've not, so prior to doing the robotic surgery, there was a Oxford partial knee that had very good data over in England. The reproductions of studies that are done in England with the United States don't always correlate, but I started doing the partial knee replacements with this called a Oxford knee 15 years ago because the results were so good. They had very good 20-year results. I think that this robotic partial knee is the cat's meow, and I think it's much more accurate. And I think that we're going to see that the longevity of these is lasting as long as a total knee. Again, that if people want to go out and play pickleball or play softball with a partial knee, maybe they won't get 20 years. Is everyone eligible for a Mako? There has been one insurance company that denied the CT scan for the Mako. That's the downside of the Mako robotic surgery is you need a preoperative CT scan, which can be several $100s. So that some insurance companies will not approve that.
Mhm.
When do you know when you need one? Well, patients often ask me, when do I need it? And I tell them I have no idea. If you fail conservative treatment and you hurt and you want to try something, then you're the candidate and you know that. I cannot make that decision honestly, but I would usually recommend if patients come to me the first time is definitely try a cortisone shot. Try an anti-inflammatory. You can try a knee sleeve. You can tie the hot and cold. Whatever you want to do is something that we'd recommend you try before you undergo a knee replacement surgery. Oldest patient. I've done a 94, 95-year-old. Honestly, I did a knee replacement on a lady, this is years ago, but she had had surgery by my grandfather, and she was a Walter Reed nurse, and then had seen my father, who was an orthopedic surgeon, and then I think I replaced her knee. She went dancing at Thanksgiving. I remember this years ago. So age is a number. It's really how active they are. I have a lot of 90-year-olds that don't want surgery. They say, you're not operating me, I'm too old. And that's their decision, not mine. When do I recommend a total over partial? Well, if you have global pain, I don't fight with patients. If they want a total, they've talked to somebody else and they're worried about the rest of the knee wearing out, then they'll get a total. I kind of push the partials more in the 50, 60-year-olds, but I'm doing a 77-year-old partial knee next week. So it all depends on, I think that it's easier to recover from and or they're doing well. If they didn't do well, I would do everybody a total. Biocartilage. I wish we had a good cartilage replacement surgery done. I have done some biocartilage and I think it can buy some time. Those cartilage replacement surgeries are when you don't have x-ray changes of arthritis. It's basically that normal x-ray when there's loss of cartilage and you're young. That's something to try. I will admit that I had a plug of cartilage put in my knee. It was a cadaver piece. I kind of wish I'd never done it, so I don't think that lasts forever. I don't think that is, but so biocartilage is an off-the-shelf cartilage replacement that is easy to do. So is a cortisone injection doesn't give you relief after several successful ones. Doesn't hurt to try another one. You could try the gel injections at that point. It may be that they're coming to an end, but you could always do another one. If you have a torn ACL, well, the indications are if you have a torn ACL is probably not to have a partial knee. There are some, it depends on how stable or unstable the knee is, but we usually like patients to have a intact ACL for a partial knee. Total knees, we actually take the ACL out. So it doesn't matter about that. If you have osteoporosis, there a risk of pins inserted in the robotic could crack the bones. I will tell you, years ago, I had one get a crack in the bone. I used to stick the pins through both cortices of the bone. The bone is round and it's hollow in the middle. So there's a bone on the ends, just like a stick. There's on the both edges. So I actually now only stick the pins in halfway. I've had no problems with that and no fractures, cracks in the bone since that time. The kneecap, yes, will be corrected the question is, if somebody has a kneecap that doesn't track normally, do you try to center that? Yes, you usually will try to center that during the knee replacement surgery. Is body weight squats? Okay, yes. There is really no other option for knee replacement surgeries than metal. There are some all poly tibias instead of a metal back tibia that's being done mostly for cost savings, but you still have a metal femur. Can you jog after total replacement? I will tell you that my sister has a bicomp replacement, kneecap and medial compartment, and she plays tennis 6 days a week. And she's much more comfortable now than she was prior to her surgery. Total knee, could you jog? Again, no guarantee for that after surgery. Um, can the cartilage between the knees be replaced? The biocartilage question earlier was about putting cartilage back in the knee. There are some procedures when you have normal x-rays, but once the x-rays have progressed to bone on bone, you really cannot there's no successful operation to put cartilage back in the knee. Is there a better time of the year to have this surgery? There is no good time to have surgery. It messes up your life, and it just depends on what you like to do. What if you're allergic to aspirin? Well, we have some people on other types of blood thinners. Usually we have their medical doctor prescribe it, but in the past we use Lovenox, we use other anticoagulants. So if you're allergic to aspirin, we'd like to put you on something because there is a risk of blood clots. Risk of circulatory issues in the lower extremity, that is usually addressed with your vascular surgeon prior to, if there's any problem, then you get clearance by them prior to surgery. I have no experience with 3D printing of replacements.
There's a lot, but
So what is the side effect of cortisone or gel injections? There is really no, I mean, people will worry about cortisone that the may cause cartilage breakdown. There's no real proven study on that. We know that we don't like to inject cortisone into tendons. Like I'll limit how many I'll do in a rotator cuff. It does make the tear may irreparable if you give a lot. For a knee joint, it depends on age. If somebody's in their 90s is refusing surgery, doesn't want surgery, I've given shots once a month for a knee, and they've done okay. Younger patients kind of hold off. I mean, we usually don't inject kids, and then the number of injections that people will get depending on age. So I have people come in once a year for a shot, and I don't really have any problem with that, and have not seen any downside. There is really no side effect of the gel injections, except you usually don't get the immediate relief, and it's kind of one of those where patients tell me they think it helps. Can a 76-year-old have a knee replacement? Yes. My knee hurts while running and climbing stairs, but not a lot. Well, if it doesn't hurt a lot, don't have it replaced. Try to keep this knee and keep running and skiing for 5 more years prior to having your knee replaced, if you can do it. I have a torn ACL and bone on the outer side, on the lateral compartment since working out. I haven't had any pain. No, do not have your knee replaced if you don't have pain. Again, another question, with no pain but with bone on bone, am I a candidate for a full or partial? I would tell you you're not a candidate for anything. Don't have it done if you don't hurt. I'm 44 years old. I had a knee meniscus surgery 4 years ago, but still experienced knee pain. I've also had steroid gel, PRP injections, post-surgery. Yeah, you might need a partial knee. I would think at 44, you would be looking more at a partial. Hopefully it's just the one side where your meniscus was taken out. So do you need stairs free environment after knee replacement surgery? No, you're hopefully getting up and doing stairs right away with support or protection. You can put full weight on any knee replacement surgery. Infection rates, well, they are luckily very low. And those can be disastrous. If we get them early, if somebody has an infection, if we go in and take the plastic out and wash everything up and get it early, that's beneficial. If it's late, that's why we put usually people, a late infection, somebody's had a knee replacement and gets one later in life is always a risk. And those can be problematic. Luckily, we do not see a lot of those. So the question is about dental work before antibiotic treatment before dental work. Well, the reason we do that is mostly from the cardiac literature with valve replacements, because there's a showering of bacteria in our bloodstream when you get your teeth cleaned and so the orthopedic literature just sort of follows that and usually gives people antibiotics prior to any dental procedure. Some people do it for 2 years, some people do it for life. I'm kind of at least minimum of 2 years, but sometimes just give it to people to do it for life. So what is fludarabine shot? I had one 2.5 weeks before, but still I did not feel better. Then it's not working. You could go back and get a cortisone shot on top of it, but there's, again, not everybody gets relief. Good.
Thank you.
Okay, thank you very much.
Thank you, Dr. Peterson, for everything. It was a great lecture. Please remember, everybody, that we will be sending this recording out to everybody after our call, and as well as scheduling links. And if you need anything, please feel free to reach out to our call center. And have a great night. Thank you, everybody.
Very good.